I'm going to talk about complex congenital heart disease, which is pretty much what you have to learn in entire cardiology, and I'm going to cover that in an hour, okay? So, disclosures, I have none, except, as was mentioned earlier, I'm an imager, so there will be a lot of images in my talk and in your boards, so please try to pay attention. When I think about complex congenital heart disease, it goes from fetal period to way into ACHD time frame, and I try to divide this into obstructive right and left heart lesion, single ventricle physiology, some cardiac physiology, specifically the clinical aspects of it, and I will touch briefly on abnormalities of great vessels. So I'm going to talk about clinical presentation, pathophysiology, intervention, and genetics. Now, there is a separate talk on cardiovascular genetics specific to cardiomyopathy, but what I'm going to cover is how genetics links with congenital heart disease very briefly. Okay. So you can classify heart disease in different forms based on symptoms, anatomy, physiology, and genetics. But what I will want to start with is this national screening algorithm for critical congenital heart disease. As you know, in 2011, the Secretary of Health launched this universal program where all babies who are born in the United States are going to be screened with this pulse ox screening so that we don't miss critical congenital heart disease. Few points to remember about this is: one, it is performed at or after 24 hours. You measure saturation in right hand and feet, and if your saturations are less than 90% on either side, the baby fails the test. If the saturation is more than 95% on both sides, and there is a less than 3-point difference, the baby passes. In between, you have to repeat this, and if the baby fails again, then the baby needs a cardiology evaluation and an echocardiogram. One of the important things to remember, again, there are these stars throughout my talk. These stars denote important facts or questions that may be asked in your boards. So non-cardiac disorders can make a baby fail the test. For example, pulmonary hypertension, meconium aspiration syndrome, septicemia, pneumonia. In all these cases, there may be a right to left shunt and there may be lower limb cyanosis. So the baby can fail a test. The two important lesions, left heart obstructive lesions, may not be picked up on pulse ox screening. These are false negative. Coarctation of aorta, an interrupted aortic arch, and even aortic stenosis may be missed on the screen. So the sensitivity is a little lower than what we want from a screening test. So this is an important thing to remember. Now let's talk about, once you diagnose a baby with congenital heart disease, they can be classified based on physiology into obstruction of systemic blood flow. So you have a ductal-dependent systemic blood flow, and when the ductus close, these babies present with shock, and usually because of acute increase in afterload, there is ventricular pressure overload and dysfunction. Obstruction to the pulmonary blood flow or ductal-dependent pulmonary circulation, you have right to left shunting, and that's what causes cyanosis. See, we always think about cyanosis as a result of decreased pulmonary blood flow, but typically it's not because of decreased pulmonary blood flow, it's because of the shunting, right to left shunt, the mixing of the blood that causes cyanosis. And then you can have a balanced pulmonary blood flow and systemic blood flow, transposition, where the circulation is in parallel, volume overloaded condition, left to right shunt, which I will talk extensively after my break. There is contractile dysfunction, and lastly, two ventricle versus single ventricle physiology. So this is how we are going to approach this. So I'm going to go through a variety of cases to illustrate some of the issues associated with these heart disease and their presentation. The first case is of a 3-year-old full-term infant acutely developing feeding and breathing difficulties. The baby is described as dusky. The patient is in respiratory distress. There is tachycardia, murmur, gallop, hepatosplenomegaly, poor capillary refill. There is right ventricular hypertrophy, large heart on X-ray, increased pulmonary vascularity, but on giving 100% oxygen, there is increase in PO2 to 120. okay? So you have a child who is perfusing poorly, there is right ventricular hypertrophy and increased pulmonary vasculature. What is this? This is a typical presentation for an obstruction of systemic blood flow. Systemic flow becomes inadequate when the PDA closes, as seen in critical coarctation of aorta, interrupted aortic arch, critical aortic stenosis, single ventricle with obstructed systemic blood flow, as in HLHS. As you can see here, the PDA is closing. The short axis view, the PDA is closing, and this is when the baby is typically present when they have a systemic outflow obstruction. Okay, so everyone recognizes this picture of coarctation of aorta. There is distal displacement of the subclavian artery, narrowing of the aortic isthmus. So in newborn with coarctation, the right ventricle is dilated. The right ventricle still is the predominant ventricle, and through the ductus, it supplies the systemic circuit. There is right ventricular dilation. But in chronic or late presentation of coarctation, there is LV dilation and dysfunction. Again, the star is here denoting an important transition point, an important question that may be asked in your boards. Okay, so late presentation, LV dilation and dysfunction. On arch imaging, there is typically two population of cells, sawtooth appearance, continuation of forward flow in diastole, both in the abdominal aorta as well as in the arch, very typical for coarctation of aorta. If you see this picture, you think about coarctation of aorta or narrowing proximal to the area where you're interrogating. So acute obstruction of systemic blood flow in neonates, they present with rapid onset of symptoms. Respiratory distress is common, reduced systemic output resulting in metabolic acidosis, sick newborn, poor pulses, easily confused with rule-out sepsis. You will most likely have a question where one of the differential will be rule-out sepsis. Don't get sidetracked. These patients have left heart obstructive lesion or poor systemic circulation. Acute obstruction of systemic blood flow neonates, how do you manage? Start prostaglandin, early diagnosis, rapid intervention, inotropic support if the blood pressure is too low. But remember, once you establish good blood pressure, you open the PDA, it is important to reduce the afterload and decrease the SVR, allowing the ventricle to contract. So initially when the baby comes in, start prostaglandin, you may need dopamine or epinephrine, but once you establish the circulation, start milrinone, allow that ventricle to contract, allow the SVR to go down. Mechanical support to decrease the workload on the ventricle, as well as lung recruitment, is an important ancillary measure that can improve the patient's condition. Okay, Amy presented some of the pressure volume loops. Acute increase in afterload results in acute reduction in the cardiac output. The newborn ventricles, because of the inherent diastolic dysfunction, is unable to handle the acute increase in afterload. So these patients tolerate acute afterload increase very poorly. In chronic conditions, as the patients get older, there is concentric hypertrophy of the left ventricle, there is decreased wall stress, and the cardiac output does not decrease as much. So in late coarctation presentation with LVH, they are able to handle this increase in afterload more efficiently. Okay. So second case is of a 3-month-old infant, chronic feeding difficulty, failure to thrive, history of respiratory difficulties and pneumonia, tachypnea, retraction, hepatosplenomegaly, single loud S2, symmetric pulses, there is biventricular hypertrophy, cardiomegaly, hyperinflation, increased pulmonary vascularity. Again, later presentation, little later, the pulmonary vascular resistance have dropped. This is pulmonary overcirculation. This is volume overload. Left to right shunt, increased flow to the lung, wasted or ineffective pulmonary blood flow. The blood that was ejected from the right ventricle is coming back to the right ventricle, so ineffective pulmonary blood flow. Okay. All kinds of shunts, VSDs, arterial level shunts like PDA and truncus. Atrial shunts or ASDs are less commonly associated with volume overload, but in patients with chronic lung disease, this may be an issue and they have to be fixed early. TAPVR without obstruction, single ventricle with excessive pulmonary blood flow, DTGS can sometimes be missed with VSD, and then there is AV malformation. So again, we talked about this You should know this: the feeding difficulty, increased respiratory rate, diaphoresis, low systemic output, common presentation for left to right shunt. Okay, how do you treat it? The most effective treatment for left to right shunt is surgery. Okay, there was a time when we tried to nurse these kids through the acute phase of left to right shunt by giving diuresis after load reduction. Those are things you can do, but even in most cases, you are doing this awaiting surgery. So optimize systemic output. You can give inotropic support, maximize hemoglobin or optimize hemoglobin to increase oxygen carrying capacity. You can do manipulation of PVR and SVR. Systemic vasodilators like enalapril is used, although with limited data to support it. Ventilatory management to increase PVR, avoid hyperventilation and excess of IO2. So how do you treat a patient who has large or high amount of pulmonary blood flow, right? Whether it is a two-ventricle kid or a single ventricle kid, the methods are common. Avoid hyperventilation, okay? pH should be less than 7.4. Permissive hypoxemia or lower FiO2, give room air. Sometimes people mix nitrogen in the oxygen to decrease the FiO2. Oxygen saturation goals are between 75 and 85 because the QPQS is in that sweet spot of 1 to 1 in that oxygen saturation range. Optimize lung recruitment. Pulmonary function should be optimal, so maintain open lungs to assure good gas exchange and decrease VQ mismatch. Okay, so third case is of a 1-day-old full-term infant, initially was feeding well and appears healthy, acutely become cyanotic, 1-day-old. Tachypnea, increased work of breathing, severe cyanosis, there is RVH, and on X-ray there is decreased pulmonary vascularity. The child fails the hyperoxia test. Okay. This is a classic presentation of a ductal-dependent pulmonary blood flow. Your hyperoxia test, although we don't do it routinely, you will see some of the questions that typically talks about this hyperoxia test. We don't do it very often in clinical practice. What are the conditions? Critical pulmonary stenosis, TET, Epstein's anomaly, especially when there is functional pulmonary atresia, single ventricle with PS, TAPVR with obstruction. Let me show you a few examples. You see this picture in your board. You see that X-ray, and that picture, you see this red flow in the crab view going up towards the neck from the pulmonary veins. You have to get this. If you don't get this, I will feel really bad, okay? So this is TAPVR, okay? Hazy lung fields, pulmonary venous obstruction. Think about pulmonary venous obstruction, okay? There is dilated right heart. The left heart is small, but it is small not because it is actually hypoplastic. It is small because it is compressed by the dilated right heart. It is still apex forming and is functioning normally. And this is a very typical finding. When you see this in clinical practice at the atrial level, predominantly right to left shunting, the blue color, think about TAPVR. I mean, my mentors used to say there are two kinds of cardiologists, ones who have missed TAPVR and ones who are going to miss TAPVR. I want you to be the later kind, okay? So predominantly left to right shunting at the atrial level, very, very abnormal, okay? So these are the clues. Obstructive TAPVR is a surgical emergency. In this time when we have a prostaglandin, most of these cardiac conditions are no longer surgical emergency, but this is, patients usually need to be taken to the OR soon. Okay, box-shaped heart, this picture if you get, this is neonatal Epstein's unless proven otherwise. Functional pulmonary atresia, you can see it in neonatal period or in fetal period. The idea is that all of the right ventricle output is going back into the right atrium. The right ventricle is not able to generate enough pressure to open that pulmonary valve. So there is functional pulmonary atresia, and this picture is pretty typical. There is apical displacement and tethering of the septal leaflet of the tricuspid valve, huge coaptation defect, huge right atrium. In cardiology or in any other science, there are few things where there is a clear cutoff. This is a place where there's a clear cutoff. If your displacement index is more than 8 millimeter per meter square, meaning by this displacement index from this hinge point to where the valve actually moves, that is more than 8 millimeter per meter square, it's abstains, okay? So this is a case where there's a clear cutoff. Mild forms of abstains, you actually have to measure that. Again, here you can see a patient with functional pulmonary atresia. There is no forward flow. All you can see is some regurgitation, and the pulmonary arteries are supplied by the ductus. Okay. Serlin-Meyer index is essentially an index of the atrialized right atrium and the right ventricle to rest of the chambers of the heart. If this index is more than 1 or more than 1.5, your prognosis or risk of death is pretty high, okay? Another thing people like to ask a lot is the circular shunt of death in Epstein's anomaly. So if you have pulmonary regurgitation, significant pulmonary regurgitation, what happens is TR goes to the left side, goes out into the aorta, comes back to the PDA, and because of the PR, goes back. Again, English is not my primary language, but when you draw it out, it is not a circle, it's a loop. So I want to redefine this. It's the circular loop of death, okay? So PR, very, people like to ask this all the time. TOF with absent pulmonary valve, okay? If you see this picture, to and fro flow across the pulmonary valve, think about TOF with absent pulmonary valve, okay? Even though they say it's absent pulmonary valve, it's a misnomer. Usually there is remnants of the pulmonary valve, but it is very dysplastic. Majority of these patients do not have a PDA. They have huge PAs. The airway compression secondary to huge PAs is one of the common reasons why these patients present. One of the things the board likes to ask is how do you manage them? Prone position and positive pressure ventilation. Why it works? When you put these babies prone, it takes the pressure of the airways, pressure of the pulmonary arteries away from the airway. So it helps with ventilation, okay? So remember that, again, the red star comes back. How do you manage acute decrease in pulmonary blood flow? Prostaglandin, the good old prostaglandin, when in doubt, it's the vitamin E. Oxygen sedation, lung recruitment, alkalinize to decrease the pulmonary PVR, okay, sildenafil and nitric oxide. Another question which is very commonly asked is how do you manage TET spells, sedation and morphine? Increase preload, give fluid bolus, okay? You have a thick right ventricle, increase preload, it feels better. Beta blocker, avoid excessive inotropes, increase SVR. This is commonly asked. Phenylephrine increases SVR and shunts the blood back from the left ventricle to the right ventricle, improving the flow into the lungs. Knee-chest position does the same thing. When you put the baby in knee-chest position, it increases the SVR, okay, shunting the blood back into the pulmonary circuit. So, one of the favorite questions that board like to ask. Fourth case is of a one-day-old, full-term infant, noted to be cyanotic, mildly tachypnic. This patient is cyanotic. He's happily cyanotic to start with. Symmetric pulses, single S2. Whenever you hear single S2, think about transposition or a single ventricle physiology. Right ventricular hypertrophy, normal heart size, egg on end appearance, because the pedicle of the heart is small. Why? Because the aorta and the pulmonary arteries are anterior posterior to each other. They are not side by side. So the pedicle is small, the heart looks normal size, and the patient fails hyperoxia test. What is this? Transposition. So instead of you have a circuit, normal circuit or normal circulation that is in series, there are two parallel circulations that are not talking to each other. So there is excessive pulmonary blood flow, but ineffective pulmonary blood flow. You need areas of communication between these two circuits, at the atrial level, at the ventricle level, or at the aorta level for mixing. The best mixing happens at the atrial level. You can have a patient with TGA and VSD who is desaturated because there is not adequate atrial mixing because of streaming. So atrial mixing is critical. So moderate to severe cyanosis, happy tachypnea, but once the cyanosis becomes worse, the cardiac function goes down and these patients can go into shock. Transposition patients often have elevated pulmonary pressures and they can have PPHN, okay? We all know the transposition echo. If you don't, I will be worried at this stage. But parallel arteries, PDA that is bidirectionally shunting, you have a restrictive atrial septum. This picture here, there's a high mean gradient across the atrial septum, not the peak. You know this patient has restrictive atrial septum. Atrial mixing is critical, okay? In fact, you can stop the prostaglandin in many cases once you establish atrial mixing. What do? Balloon atrial septostomy is the method of choice or treatment of choice. You can give prostaglandin in between, but you are not going to establish atrial mixing. So atrial septostomy, optimize systemic output, minimize pulmonary edema, but atrial septostomy to reestablish or establish a good amount of pulmonary blood flow. Okay, this is another question that is very commonly asked in boards, is reverse cyanosis. So if you have a patient with transposition who has coarctation or elevated PVR, what happens is the PDA can shunt the blood from the left side to the lower part of the body. So you have higher saturation in feet and lower saturation in head and neck region. So this is reverse cyanosis. Think about DTG and coarctation or elevated PVR. Okay. So fifth case is of a five-day-old full-term infant with acute respiratory and feeding difficulties, color change. The child is looking dusky, 5-day-old. Tachypnic, shock, single S2, no murmur, poor pulse, RVH, large heart, increased pulmonary vascularity, failed hyperoxia. I talked to you earlier about this. If you hear single S2, think about transposition, but here you have a large heart, an increased pulmonary vascularity, and the patient is in shock. This is unlikely to be a transposition. What is this? This is a single ventricle, probably a systemic circulation that is PDA dependent. Rapid onset of or rapid deterioration of the child's status once the PDA closes, often no murmur because the PDA has closed. This is decreased systemic output, metabolic acidosis, profound shock. Okay, so if it is ductal dependent pulmonary blood flow, usually there is profound cyanosis. I'm going to talk briefly about single ventricle physiology, okay? Please pay attention to this because some form of question related to this will be asked in your boards. Essentially, a single ventricle is pumping blood into both systemic and the pulmonary circuit, okay? So the RV or LV is pumping blood into both systemic body and the lungs. So there is a balance between QP and QS. This interplay is critical in these conditions. The PVR and SVR really matters here because once you modulate one, the other will be changed, right? So how do you change oxygen saturation and oxygen delivery in a single ventricle patient? One is you change the QP-QS. Second, you increase or decrease the systemic venous saturation, which is determined by cardiac output and hematocrit of the patient. And lastly, pulmonary venous saturation, okay? And these are mentioned in the order in which you can change them. Okay, let's talk about it. So how do you increase pulmonary blood flow or increase QPQ or QP to QS, right? So if you have high QP-QS, it's usually well tolerated. Patient will be in heart failure, but usually the patient will be saturated okay and is well tolerated. Pink with poor perfusion because there is steal of blood into the pulmonary circuit and there is decreased flow into the systemic circuit. There is wide pulse pressure, oliguria, metabolic acidosis if it persists. Excessive pulmonary blood flow causes high atrial pressure and pulmonary edema. Okay, so how do you manage it? Systemic vasodilation. So what you do is you decrease the SVR. So you're promoting more blood flow into the systemic circuit. Milrinone or nipride, optimize hematocrit. In a single ventricle patient, this is always important. Optimize hematocrit. PVR manipulation to increase PVR, decrease FiO2, we talked about this. Increasing PEEP, positive pressure, will increase the mean airway pressure and increasing the PVR. How do you optimize SVC saturation? By augmenting cardiac output. SVC saturation is a mixed venous saturation. It essentially tells you how good your systemic blood flow is. So you augment total cardiac output, optimize hematocrit, and lung recruitment is always critical to manage PVR. Treat residual anatomic lesions, sedation, ventilation to minimize O2 needs. Okay. Now, if you have a decreased pulmonary blood flow, what do? You treat the anatomic causes like shunt obstruction. Elevated PVR can be secondary to pulmonary infection, venous obstruction, or restrictive atrial septum. So increasing the QP-QS, systemic vasoconstriction. So if you vasoconstrict the systemic circulation, more blood is going to go into the pulmonary circulation. In fact, if you have a hyperplastic left heart patient who is post stage 1, and he comes to your clinic, and you saw him 2 weeks ago, and his saturation was 82%. He comes to you, and now his saturation is 90%. You should be concerned, right? What happened here is the SVR increased. Why did the SVR increase? Most likely, there is coarctation of aorta. So the SVR went up. So you should not be happy that the saturation went up. You should look for a cause for it. Because eventually, this patient is going to fall apart, okay? So increased QP can be achieved by increasing SVR or by lung recruitment, and rest remains the same, optimize SVC SAT, all of those things. Reduce systemic venous saturation. As I said, the systemic venous saturation essentially is a saturation in SVC. So the body has taken up as much oxygen as it wants before it comes back to the heart. So if you have a low systemic saturation or systemic venous saturation, that means that the circulation is sluggish, the cardiac output is low. So what do? You optimize myocardial protection, minimize oxygen requirement, address underlying cause. For example, if there is lack of AV synchrony, like it's not in sinus rhythm, in a jet rhythm, you treat that, balance QP to QS. Inotropes are really helpful here, milrinone, calcium channel block, or calcium chloride, stress doses of corticosteroid and vasopressin. So think about what is happening to the baby when a clinical scenario is presented to you, and then think about the changes you will make to either increase the QP, or decrease the QP, improve the systemic blood flow, and lastly, improve the pulmonary venous saturation. For improving pulmonary venous saturation, there is not much you can do but make the lungs better, okay? Like decreasing the PEEP. If there is a collapse of a lung, you open it up and things like that. But mainly you play with the QP and QS. And always remember to address anatomical issue like coarctation, stent thrombosis, or shunt obstruction, okay? Since I have to cover a lot of topic, this seems a little disjointed, but I just want to talk to you about this briefly, okay? You will get a question from this table, okay? So if you memorize this table, at least you get 2 points, okay? So what they're going to ask you is not like what are the genes responsible for TOF. They will present you with a clinical scenario and you will have to find out what gene is responsible. The main thing to remember is tetralogy of Fallot, Alagille syndrome, JAG1, bicuspid aortic valve, Notch1, PS and supravalvular PS. Either it is Williams syndrome where the mutation is an elastin gene, but you can have a mutation in elastin gene without being a Williams syndrome, PDA, myosin heavy chain, and things like that, okay? Just a miscellaneous quick facts. They love to ask this question, that is clinical decision making in PAIVS, okay? So in patients with pulmonary atresia and intact ventricular septum, the most important thing that you can think about is the tricuspid valve Z-score, okay? So the patients are divided into 3 groups. The group C is when the tricuspid valve Z-score is less than -5. These are tiny ventricles, often associated with sinusoids, coronary sinusoids. The RV is unipartite, meaning by just has one part, and these patients are going down the single ventricle pathway. You do not decompress this RV. But if your tricuspid valve Z-score is more than 2.5, usually the ventricle is tripartite, there is no significant coronary sinusoids, and these ventricles can be, decompressed. So you do radiofrequency valve perforation. Now you will ask, some of these patients rarely can have RV-dependent coronary circulation, yes, it can happen, but it is pretty rare. In fact, there are centers in Australia and New Zealand where all they look at is the tricuspid valve Z-score. If it is more than 2.5, they assume that it's not an RV-dependent coronary circulation, and unless there is an osteostenosis of the coronary artery, they will go ahead with decompression. So tricuspid valve Z-score. In the intermediate range, you may or may not open the pulmonary valve based on cath findings. And here, they may go down a 1.5 ventricle repair. You have to do stenting, BT shunt to tide over the crisis, and then go for a 1.5 ventricle repair later. So tricuspid valve Z-score less than 2.5, more than 2.5, less than 5, and in between. Critical to remember. Another thing very important to remember, not only for your exam and for your test, is I do fetal counseling, and I'm still surprised to see that we offer termination of pregnancy as an option in hypoplastic left heart, but not in PA-IVS, which is wrong in my opinion. The reason is, in patients with pulmonary atresia intact ventricular septum, if you have a patient going down a univentricular pathway, a single ventricle pathway, they have worse outcome compared to a hypoplastic left heart. If you look at survival, there was a recent study and many other studies, the survival of a unipartite heart, meaning by a small right ventricle, the 1-year survival is 44%, while for hypoplastic left heart is 65 to 70%, and 5-year is 22%, and this remains a problem even in adulthood. So, pulmonary atresia with intact ventricular septum patients who are going down the single ventricle pathway are high risk for sudden death secondary to coronary abnormalities. Important to remember. You may get some form of that question. This is a pet question for them to ask. In double inlet left ventricle, where is the aorta? I mean, I don't understand why it is so important, but it is important. It is leftward and anterior, okay? The second thing you have to remember is that most of the, if you have an L-looped ventricle, meaning by the RV is on the left side, then the conduction system is anterior to the pulmonary outflow. If it is D-looped ventricle, it's lateral to the pulmonary outflow. Most importantly, the surgeons cannot go in and make the bulboventricular foramen or the VSD that connects the big ventricle to the small RV bigger because the conduction system is intimately associated with it, okay? Many, many years ago, when you guys were, still in grade school probably, someone published from Boston this paper about bulboventricular foramen size, okay? If the bulboventricular foramen size is less than 2 centimeters square per meter square, there is more likelihood of late obstruction to the artery that is coming out of that small chamber. So if it is the aorta, you do a DKS procedure. Again, another question that they really like to ask. Remember the 2 centimeters square per meter square number. If the bulboventricular foramen is small, then you may have to do a DKS. Otherwise, they may have late obstruction. There is a case of tricuspid atresia, 4-chamber view, platelet atresia of the tricuspid valve, right atrium, left ventricle. There is hardly any right ventricle. You can see here, pulmonary artery is arising from that big ventricle, nice branching here. And then you see this. You see a smaller aorta arising from the smaller chamber, right ventricle. You can see the size discrepancy between the aorta anteriorly arising from the small chamber. There is a VSD and the large PA. What do you suspect? This. The 3 Fs, the rule of 3 Fs, form, flow, form, function. So if there is less flow, the formation of that chamber is small and the function is reduced. So essentially what this patient had was an interrupted aortic arch, okay? I'm not sure why this is not looping, but this is an interrupted aortic arch. So the artery that is arising from that smaller chamber is going to be small. So if it is pulmonary artery, think about pulmonary stenosis. If there's aorta, think about coarctation or interrupted aortic arch, right? So that's that. So now very briefly, I'm going to talk about trials, okay? We lived in an era where we practiced the art of medicine without much evidence. But in last 10 to 15 years, specifically because of Pediatric Heart Network, where the NIH-funded big network that many of us are part of, we now have evidence based on randomized trial. One of the landmark trials is this SVR trial. You should know at least the salient features of this, okay? There is a push towards including these in the boards. Adults always included major trial results in their board question. So the SVR trial, we are into third SVR3. The first one was published about more than 10 years ago now. And what it showed was that at 1 year, the RV to PA conduit group had better survival compared to the BT shunt group. This was a randomized trial of the normal procedure in hypoplast, 74% versus 64%. That was what the first trial showed. The second trial, SVR2, looked at 3 year. There was no survival advantage, 67% versus 61%. But the RV to PA conduit group had a slightly lower ejection fraction, and they had more incidence of catheter intervention. And this was the more recent publication. At 6 year, again, there was no survival advantage. So you will ask me, so what does it all mean, right? What it means is you have to survive the first year to become 6-year-old. So the survival advantage that happened in the first year still persists, okay? Unfortunately, there has not been a great shift in the way surgeons do BT shunt versus Sano based on these results. Pretty much surgeons do what they are trained to do, but this is the results of the trial that you should remember. Survival advantage in the first year, more cath intervention, and decreased function in the second trial. And in the 6-year trial, which is still ongoing, the third SVR3, there is no survival advantage. Okay. This is the another study that was funded and was done by the Pediatric Heart Network. This was a randomized double-blind trial of enalapril in infants with single ventricle. And what they did was they administered enalapril to infants with single ventricle physiology, and they looked at outcome in the first year. This was a negative trial, did not improve somatic growth, ventricular function, or heart failure severity. Despite this, 80% of patients with single ventricle are still on enalapril. Okay, we really are not great at learning from trials. Okay, so Marfan trials, again, it was a negative trial. There was no difference between atenolol and losartan, just to mention that. Okay, switching slightly, this is my last topic, Fontan. Okay, Fontan presented his paper in 1970s, early 70s. It's been 45, almost 50 years to the initial publication. And when Fontan published his initial paper, he talked about what a normal Fontan, the kind of patient who should have a Fontan and what a normal Fontan should look like. And to a great extent, it still holds true. Some of the numbers to remember are PA pressure should be less than 15, okay, in a Fontan. The Fontan pressure should be less than 15. Transpulmonary gradient, meaning by the pressure difference between the PA, the circuit in the SVC and the LA, the transpulmonary gradient should be less than 10, normally is 5 to 8. And normal saturation for a Fontan is in low 90s. There should not be no gradient. Even a minimal gradient is abnormal because this is venous flow. Even a small gradient can accentuate and increase the energy loss. No significant AV valve regurgitation. Fenestration shunt should always be from right to left. Okay. No systemic inflow or outflow obstruction. This is another question they like to ask a lot. Okay. So if you have a patient who has an outflow tract obstruction, and if the gradient, peak gradient, is more than 40 before Fontan, you should stage the surgery. Why? Because if you have significant outflow tract obstruction, it causes ventricular hypertrophy. Ventricular hypertrophy causes diastolic dysfunction. And if you have a thick, non-compliant ventricle, if you do Fontan, your Fontan won't work well. That's the basic idea behind delaying the Fontan, doing a staged procedure. Remember, we talked about double inlet left ventricle, how if you leave that bulboventricular foramen small, you can have outflow obstruction. Okay, so you need to address that. Normal systemic and systolic and diastolic function, normal sinus rhythm. If you get a question of a single ventricle patient who is not in sinus rhythm, okay, most likely answer is reestablish sinus rhythm. Okay, just remember that. Okay, this ECG is going to be there on your boards. Okay, the reason why I say that is because with increasing survival of single ventricle patients, majority of them are going to survive into adulthood now, okay? We have about 1,000 hypoplastic left heart kids born every year, 3,000 to 4,000 single ventricle kids born every year. They undergo Fontan, they're going into adulthood. You see this EKG, what do you think? Anyone? Come on. Flutter. Okay, Fontan, you see this EKG. Even if you didn't see this EKG, most likely it is flutter. Okay, you saw this sawtooth appearance. It is post-Fontan atrial flutter. It is intra-arterial reentrant tachycardia or isthmus-dependent fibrillation or flutter, right? IART or IDF, the more recent. Okay, don't miss this. Okay, sawtooth appearance, Fontan, IART, very, very common. The question is not if you will develop IART after Fontan. The question is when. If you follow them long enough, most of these patients, because they have extensive atrial surgery and scarring, they are going to develop intra-arterial tachycardia or SVT. Okay, another thing to remember is this. APCs or atriopulmonary connections, the old kind of Fontan has higher incidence of tachycardia or intra-arterial tachycardia than the newer ones. There is no difference so far between extracardiac conduit and lateral tunnel, okay? The survival of PLE 10 years ago was thought to be 50%, 5-year survival. More recently, Mayo published a paper about 2 years ago. The survival with conservative management has gone up to 88%. Transplant is no longer the first step in the management of PLE, okay, because the survival has improved, okay? Treatment of PLE, again, I talked to you about this. If the patient is in non-sinus rhythm, fix it, okay? Fontan pressure is high, fenestration, make a fenestration, give sildenafil. EF is low, treat that. Low fat, all of that jazz, you know, okay, you can read that. But treat the cardiac causes. Read through, you know, the note and make sure you treat the cardiac causes. One of the new kid on the block is the budesonide, oral budesonide, because now we have realized that PLE has an inflammatory component to it, which is very strong, and it suppresses the inflammatory component. Okay, Fontan-associated liver disease, this is the last topic I'm going to cover. The newest kid on the block, everyone is talking about it. There's a lot of research going on. After doing Fontan for 45 years, in the last 10 years, we realized that we are not fixing these kids. Moms and dads thought they are fixed, but they are not, okay? And then Dr. Fontan said, I never intended it to be a definitive surgery. It was just a palliative surgery because I didn't have anything to offer. When we looked at the liver, they were not normal, okay? There were 5 or 6 cases of hepatocellular carcinoma in 20s published by the Mayo Group as a case report in New England Journal. Everyone took notice. Why? Because high mechanical pressure, multiple cardiopulmonary bypass, multiple medications damages the liver, okay? They go from fibrosis to cirrhosis to hepatocellular carcinoma. There is no Fontan patient in their second decade of life, no one who does not have an abnormal liver. Everyone has an abnormal liver. The question is how abnormal it is. How do we find out? You will hear all sorts of things being said. Liver biopsy is the gold standard, but it is not because it's patchy involvement, invasive, risk of complication, follow-up, how many times are you going to biopsy? More importantly, now people do liver MRIs with a special contrast agent called EOVIST, and if you're going to get fancy, there is this magnetic resonance elastography where you measure the stiffness of the liver, even though it sounds very fancy, it is not. You send the sound waves, you get the sound waves back, and you measure the stiffness of the liver. You can do it with MRI or ultrasound. MRI is better. Ultrasound gives you similar numbers, but not as sensitive. But this is the way we are trying to look at liver. Treatment, we don't have any. There are ongoing trials of PDE5 inhibitors, okay? So that concludes my complex congenital heart disease. So 80% of your syllabus is done. Okay, thank you for listening.
Question 1. You are preparing to send home a 3-week-old female with tricuspid atresia and transposed great arteries who has no evidence of coarctation. Her oxygen saturation on room air is 85%. You are anticipating being able to skip the Damas-K-Stansel procedure. Which of the following has been shown to predict development of subaortic outflow tract obstruction in this patient? A, bipartite nature of the right ventricle. B, a bulboventricular foramen that measures less than 2 centimeters per meter squared. C, a bulboventricular foramen that measures 4 centimeters squared by meters squared. D, a bulboventricular foramen peak gradient of more than 20 millimeters of mercury. And E, aortic annulus Z-score of less than 1.5. Choose your answer. And so most of you chose B, and the correct answer is B, so excellent work. Did you want to say anything about this?
So we talked about how in double inlet left ventricle and in tricuspid atresia, when you have a hypoplastic small chamber that is communicating with a larger left ventricle, your bulboventricular foramen or VSD size should be 2 centimeters per meter square or larger. Otherwise, there is increased likelihood of long-term obstruction, right? So this is, again, the question is whether you should do a DKS at the beginning or not. This is a good predictor to think about, okay?
Next question. A full-term female newborn presents to the ED in acute cardiovascular collapse on day 3 of life. Physical examination reveals weak pulses in all extremities with strong carotid pulsations bilaterally. Echocardiogram is most likely to reveal which of the following congenital heart defects. A, critical aortic stenosis. B, interrupted aortic arch type A with aberrant right subclavian artery. C, interrupted aortic arch type B with aberrant right subclavian artery. D, right aortic arch with an aberrant left subclavian and a diverticulum of Komarol. And E, dilated cardiomyopathy with severely reduced function. Choose your answer. And a little variety here, but most of you chose C, with a couple of B and A. And the correct answer is indeed C.
So this is a board question, I know for a fact. I mean, it rotates over the years, but this is a critical question you need to think about. If you have critical aortic stenosis, right, all your pulses should be low, but what else should happen? Carotid pulses should also be low. There is no reason the carotid should be bounding or well felt, and the arm pulses, limb pulses should be low. So aortic stenosis A is not the correct answer. Neither is E, because the carotid pulses should be low. So now you're left with the 3 other choices, right? So in interrupted aortic arch type B, where is the interruption? Before subclavian. B stands for before subclavian, A stands for after subclavian, C is for in between carotid, A, B, C. That's the way to remember. So in type B, with an aberrant right subclavian, the right subclavian arises after the interruption. Okay, so all your limb pulsations are not useful in measuring the gradient because all the limb vessels are coming off distal to the area of obstruction. So this is a something to work through, but this is a question that I've seen in multiple iterations in the board.
Next question. While explaining the prognosis of a neonate with pulmonary atresia and intact ventricular septum to your trainee, which of the following will be the most important predictor of type of repair and patient's outcome? A, restrictive atrial septum. B, type of pulmonary atresia, muscular versus valvular. C, tricuspid valve Z-score. D, severity of tricuspid regurgitation. Or E, pulmonary artery annulus Z-score. Excellent work. I think we did that one very nicely earlier.
Yeah. I try to hammer this in terms of the tricuspid valve Z-score being a predictor for everything else. The larger the tricuspid valve Z-score, the less likely that there is going to be significant sinusoids, and the bigger this tricuspid valve Z-score, more developed the right ventricle. Restrictive atrial septum, unlike hypoplastic left heart, does not play an important role in the hypoplastic right heart. Type of pulmonary atresia, again, doesn't matter. Majority of them are mostly muscular, typically. Severity of tricuspid regurgitation does matter, but less than tricuspid valve Z-score. And pulmonary valve annulus Z-score typically does not matter because it can be atretic and there is no way to measure it before.
Next question. A 5-year-old with tricuspid atresia and transposed great arteries who underwent cavopulmonary anastomosis and transection and ligation of MPA is being evaluated for extracardiac Fontan. His oxygen saturation en room air is 71%. On echocardiogram, he has a peak systolic subaortic gradient across the BVF of 50 millimeters of mercury. Which would be the next best step in his management? A, subaortic resection and Fontan as a single-stage procedure. B, subaortic resection followed by Fontan procedure in 2 stages. C, refer patient for cardiac transplantation evaluation. D, perform an axillary AV fistula. E, aortic root translocation and reconstruction of the pulmonary artery. So 86% of you chose B, and then the rest of you mostly, A. And so our correct answer is B.
Okay. We talked about this when there is significant subaortic obstruction and ventricular hypertrophy. It is better to do a stage Fontan because hypertrophy of the ventricle results in diastolic dysfunction. So if you do a Fontan in a single stage, there are multiple papers talking about increased incidence of pleural effusion, and these patients take a long time to recover because the Fontan doesn't flow very well, secondary to diastolic dysfunction because of the hypertrophy. So 35, 40 is considered the sweet spot above which typically people think about doing a stage repair for Fontan because of hypertrophy and diastolic dysfunction. Again, this was one of the forms of this question is seen in the boards.
Next question. In patients with double inlet left ventricle, the most likely position of aorta in the relation to the pulmonary artery is A, side by side, B, anterior and rightward, C, interior and leftward, D, posterior and leftward, E, posterior and rightward. Choose your answer. Excellent work.
Excellent. So, yeah. The correct answer is C, anterior and leftward. Somehow, examiners have a fascination about asking this. Primarily, what they want to know is, the L-looping of ventricle is not uncommon in this condition. So the hypoplastic chamber is on the left side, giving rise to the aorta, which is anterior and leftward.
Excellent. Next question. A 3-week-old with a history of tetralogy of flow was admitted to hospital for worsening cyanosis. While performing an echocardiogram, he develops acute tachypnea with worsening cyanosis and oxygen saturation decreases to 60% from his baseline of 82. Which of the following acute interventions is contraindicated? A, oxygen, B, morphine, C, a 15 per kilo fluid bolus, D, isoproterenol, or E, phenylephrine? Choose your answer. Excellent work.
Excellent. So those of you who gave phenylephrine, they did okay. But isoproterenol is a problem, right? So this is how you have to think about the medication and its effect. Isoproterenol causes increased tachycardia, right? It causes tachycardia, and it increases the subpulmonary obstruction. So you don't want to give something that causes tachycardia. You want to calm the child down, give them oxygen, morphine, sedation. You don't want to rev them up. I can tell you in the last few years, this is a typical case. The patient is nearing surgery. You order a sedated echo. Patient goes for sedation, and as they come out of sedation, they're crying their head off and have really bad TET spell. So isoproterenol increases heart rate. It increases or it worsens the subpulmonary obstruction. Don't do that. The rest are right answers. Go ahead.
Chris. Just a small caveat. The board is likely to ask you what is the best next step in a child with a tetralogy spell. The best next step usually means the thing you can get to it quicker without having to puncture the child or having to do a procedure in the child. That if you look for the least complex answer, which would be either calming the child or knee chesting the child, which is it was a choice they used to put in. People are moving away from knee chesting children because in general also they get agitated. So the choice is the best next step in the management of somebody who's spelling could be calming the child in the choices. That might be the choice you may want to use as your best next step.
Calming the child is always the best option.
Calming the doctor.
You never want to make them mad, right? No matter what, if they're in a spell. But that is an important way to think about it, and that's what the only reason I had this question is to think about the mechanism of action of different drugs.
That's good.
But yes, calming the child, giving oxygen, typically is not a bad thing to do.
Next question. A 37-week gestation female newborn with prenatal diagnosis of tetralogy of Fallot and absent pulmonary valve develops progressive respiratory distress soon after birth. The most appropriate next step in the management of this neonate would be A, Start prostaglandin infusion at 0.1 mg per kg per minute. B, prone position and positive pressure ventilation. C, supine position and positive pressure ventilation. D, inhaled nitric oxide at 20 parts per million. E, milrinone infusion at 0.5 micrograms per kilo per minute. Choose your answer. Very nicely done. The correct answer. We sort of set you up for that with that last comment.
Yeah, so this is that question where the best next step. Why not prostaglandin? Someone, maybe one person said prostaglandin. Is there a reason why not prostaglandin? Yeah, so typically these patients do not have a PDA, and it really doesn't help. So that's one thing. And supine position, you don't want to do that because of that pressure issue we talked about. And the rest are maybe an option, but the best option immediately is to do that.
Next question. A 35-week gestation female newborn with prenatal diagnosis of severe Epstein's anomaly of the tricuspid valve develops progressive respiratory distress on the day of birth. On echocardiogram, you notice severe tricuspid regurgitation and minimal excursion of the pulmonary valve leaflet and mild pulmonary regurgitation. The most appropriate next step in the management would be A, urgent surgical repair of the tricuspid valve, B, balloon valvuloplasty of the pulmonary valve, C, inhaled nitric oxide at 20 parts per million, D, milrinone infusion at 0.5 micrograms per kilo per minute, E, urgent surgical exclusion of the right ventricle.
Okay. Urgent surgery is never usually the most appropriate next step, just as a matter of fact, except for total veins, right? I talked to you about this. So I knew how much Dr. Cabrera likes this best next step thing, right? So the best next step thing is usually the things that you can do quickly, right? By the time you pace the surgeon and get him, usually, it'll be a while, right? But think about this anyway. What you want to do is to decrease the PVR, to increase the flow of blood into the lung. How do you do that? You do that by inhaled nitric oxide, the easiest way among this choice, right? Milrinone is not a great agent in this case because you don't want to decrease the SVR, right? Decrease the blood pressure, because blood pressure will help push the blood through the ductus into the lung. So I think the next best step in this would be the inhaled nitric oxide. The best treatment in these patients is to decrease the PVR as much as possible to promote forward flow into the lung. Okay, so does that make sense? What do you think?
Yeah, I think that the other way this could show up is you're trying to make a decision about the patency of the pulmonary blood flow through the pulmonary valve and trying to determine if you have anatomic pulmonary atresia, what's being called functional pulmonary atresia, which is the fact that your pulmonary valve leaflets do not open because the PVR is still high. So when you administer nitric oxide, you may be able to resolve that over a short period of time by seeing if the pulmonary valve opens and you get Doppler flow across the valve. You may be answering the question of, was this functionally just not opening, and now with the PVR being low, the pulmonary valve will open and you have forward flow through it. Because that may make the difference between deciding that you need an additional source of pulmonary blood flow versus not.
And the best treatment in neonatal Epstein's is non-surgical treatment. Surgical outcomes are uniformly not great. Yeah, go ahead. It specifically says mild regurgitation for that specific reason.
Yep.
If you had severe regurgitation, you do not want to increase that. You want to do something to close the PDA. That would be the first thing to do.
Yep.
In fact, there is a fetal trial going on where they're giving indomethacin to the mom to close the PDA as a fetus to prevent fetal demise when there is severe PR in fetus.
Yes.
So you want to disrupt that cycle or loop or whatever you want to call it. Okay.
So to your point, you have to determine how much of a component there is from pulmonary regurgitation then to be able to say the ductus is a hindrance.
Right.
And if there's a lot of pulmonary regurgitation, the duct actually will be working against you. Right. And closing the duct might be the best next step if that is the case.
Yes. So that's why I specifically gave you the data point of mild PR. That's important.
That's great.
Good question, though.
A 2-day-old female is undergoing pulse oximetry screening for critical congenital heart disease. The right upper limb saturation is 96%, and the right lower limb saturation is 94%. What is the best next step in the management of this neonate? A, discharge home. B, repeat the screen in 60 minutes. C, refer the patient for echocardiogram. D, pediatric cardiology consult. E, discharge home with cardiology follow-up in 1 week. Choose your answer.
I'm glad that no one is discharging this baby home, which is excellent. Pediatric cardiology consult, I mean, we like to consult on babies, but what is the right answer, though? You want to bring up the right answer? Okay, so we talked about how this is the borderline case, right? So you want to repeat less than 95%, you want to repeat the screen, okay? Now, there's an app for this that you can put in the numbers and you can come up with an answer. But as a pediatric cardiologist, I would expect you to know this because NICU and nurses and midwives are supposed to know this. So it will be pretty sad if you didn't know. If they call you and you say, hey, discharge them home, that's a problem, okay? So just remember the algorithm we talked about, okay? And that's all this is. So when do you repeat it?
Yeah, so what the question is trying to ask you is, do you know what does a negative or a positive screen for critical cardiac disease with pulse oximetry is? Do you know how it's failed or how it's passed? And it's asking for you to remember the algorithm of how, you know, the upper and lower extremity gradient and saturation versus the total saturation, and when would you repeat the pulse oximetry again?
Right. Just remember it, and you know, more than 3-point difference in upper limb, lower limb, and then, you know, less than 95%, you repeat it, right? Okay.